Belograd and welcome to our BG Dental Cases video tutorials that are dedicated to clinical cases reviews. And this is episode number 4. We are really happy that we got a lot of positive feedbacks from you guys, and we are continuing to film that that content that will be useful for everybody who makes and does practical clinical dentistry. Today I would like to present you a very interesting case, very compromising case, very compromised case that is related to endodontically treated teeth and subgingival defects and pretty, let's say, dramatic isolation, subgingival isolation and preparation of destroyed central incisors. Before I will start describing you this case and process explanation, I would like to mention that again this case was really compromised and there were few options to perform dentistry in such clinical situation, and my decision was based on consultation with patient and evaluating patient's requests as well, and everything I did that time was correspond to patient demand, and I will explain you the way I was thinking, the way I was negotiating with patient, and options that we offered to the patient, and the option that we have chosen to perform that clinical case. So let's go. Here you can see two central incisors, really compromised in terms of restorative status. The one central incisor got a big caries lesion, caries defect. Another central incisor was restored with composite veneer and was also compromised because of the secondary caries. Both central incisors are endodontically treated. Okay. Also, we have caries defects on lateral incisors. Here and here you can see that. And let us go to more close-up picture so you'll be able to see a really big caries defect. When we were evaluating these pictures, we named that picture as a big caries hole here, a huge one. You see the caries itself, and also if you will imagine this demineralized enamel, so the real defect is pretty huge. Okay, the lateral view of central incisor. Here you can see also caries defect from distal area and also some caries defect on lateral incisor as well. So perfect, let's go. Another view, another angle, and here is the picture that I would like to recommend you to get as protocol for your daily basis. The reason why this picture is useful is that it shows you position and level of teeth in frontal area. And so here you can see that one central incisor is more protrusive. So basically, if we will draw the line here, you can see that the one is more protrusive than another one, considering the fact that this tooth was restored with composite veneer. Okay. And when we were evaluating 45 degrees picture and profile picture of patient's portrait, we noticed that both of them, they were protrusive. And that, just imagine, this information we evaluate, we interpret this information when we discuss the way or option to do aesthetic rehabilitation of such teeth. So considering the fact that they are protrusive, in terms of restorative approach, we have to prep these teeth too much. If these teeth are vital, I would strongly suggest orthodontic treatment, because orthodontic treatment in this case was named or was offered as an option and patient refused. But since they are non-vital, we were okay. But imagine that these teeth are vital, and if they are super protrusive and with that type of caries defects, maybe you will compromise vitality by the tooth preparation, which is not good from biological perspective. So in this case, you can see the one even more protrusive, and that has to be evaluated for tooth preparation, and also color change if color change is an issue in that kind of cases. So that picture again, the picture that was taken through central incisors, through incisal edges of central incisors, will help you to see position of teeth utilizing intraoral picture. Another picture which is also useful is picture that you can take from palatal sides. This picture will show you defects that may be visible from palatal side. Take a look here. You have caries defects, you have some filling, etc., etc. So this picture is good to have in your database and to show to your patient the real restorative status and the caries defects that your patient may not see from palatal sides, because sometimes they just come and say, doctor, I have something from my buccal surface, I'm not happy with color, or I have some white or black spot or whatever. But then you may show them also from palatal side that there is a caries defect or filling, for example, that need to be replaced. So basically, evaluating all this information, you may choose the proper restorative construction or restorative constructions, because, for example, if this patient will ask you a veneer, I think that veneer is not a good option in that case. It's not because of the endodontic treatment, it is because of the tooth structure lost, both from vestibular and from palatal area as well. So in that case, maybe the crowns will be much better. Anyways, endodontic treatment was not that difficult. We made retreatment. The reason why we made retreatment is because caries lesion was in pulp chamber, which means bacteria are already in root canals, and I don't want my patient come back after a while with new crowns and apical periodontitis because of the inflammation. Actually, that's why. So again, let's go back to diagnosis and treatment planning in that case. Considering the fact that teeth were protrusive, as well as problem that is related to biological width, because that type of caries defect was subgingival, dramatically subgingival. In this case, the biological width was violated by the defect, and it would be violated by the preparation. So what we can do orthodontic treatment. We can actually bring teeth slightly intrusive, and also we can do orthodontic extrusion, then do the treatment, and biological width will be not that compromised, and also the position of teeth will be not that compromised. The amount of preparation will be less. Okay, orthodontic treatment was refused by patient. So the second option that I offered is that we need to do crown lengthening. In that case, with that big caries defect, with that such deep caries defect, crown lengthening is a good option, because again, if you will redesign biological width, you may get really good outcome and a good architecture of the soft tissues afterwards, because all of us, we saw some patients with crowns and with a red or even some kind of bluish gingiva around the crowns, not because of the crowns are PFM. Even we can see a lot of cases with metal-free ceramic restorations and with such inflamed gums because of the biological width. So in this case, we offered crown lengthening, and crown lengthening also was refused. And considering the fact that the teeth are non-vital, and patient was super afraid about surgery, literally she was really afraid. And I said, okay, if we will do just restorative treatment, from my side, I would be super accurate in terms of fit of restoration, because in this case, fit of restoration will play main role. If fit will be okay, maybe you will get good result, because the biological width after a while may be redesigned by the patient's organism. Anyways, I said that there is a risk. In that case, if we will just go for restorative treatment planning, and we have to discuss with patient, and we have to realize these risks by ourselves. So actually we can have three outcomes. First, inflammation. Second, recession. And the third, everything will be okay. I cannot give you exact statistics according all these three outcomes, but two of them are risky, another one is good. So everything has to be delivered to the patient, and patient has to share risks for the final result with you, because you are not just one who will be responsible in that case. If you don't want to take responsibility by yourself, in case if patient doesn't understand, it's better not to take this case. Okay? So in that case, we decided to go for restorative treatment, and in this case we are not changing color of teeth. We need to integrate two ceramic crowns into the biological or aesthetic envelope of our patient. So basically we need to fit crown of our metal-free crowns with adjacent teeth. So in that case, it is really important to share with your dental technician enough information about the color. And one of the best options to share information with your dental technician with color is to utilize polarized filter. Polarized filter removes highlights from the surface, and you can see the core color of dentin. If you will take picture also with some shade guides, with a Vita shade or maybe with the shade guides that your dental technician uses for ceramic build-ups, it will be better because he will be able to understand more clear and more precise the color. So after this, we started with first step of treatment, and first step of treatment was initial preparation. The initial preparation was pretty simple. I just made depth cuts. The depth of these depth cuts were driven by the color, by the thickness of ceramic crown to give us color that we want. In that case, we discussed with dental technician that issue, and he guided us regarding the color that he wants. And then, after making these grooves, we started with another step of preparation, which was separation and let's say the main reduction. The main reduction was done with tapered burrs or cylindric burrs, doesn't matter, with coarse burrs. And also we removed caries during this step of preparation. And only after that we went into the endodontic treatment and then to the final step of preparation. This sequence has some benefits. First, after you finish step 1 of preparation, you understand the geometry of the final design of prep, and it may help you to choose exact amount of build-up material to save your time. So that is interesting approach when you do endo, but first you do restorative part before you do endo. Another super important issue is that after initial preparation, after removal of the caries, after removal of old fillings, etc., you may evaluate restorative status of teeth. In other words, you may understand if you will be able to restore this tooth afterwards or not. If you cannot restore, extraction and implant. If you can, you go. But before that, you explain this with your patient, and then if you will say that we have to extract this teeth, unfortunately, that will be not surprise for your patient. Okay, so you have to give these options to the patient as well. And another benefit for that step, when you do step 1 of preparation, is that the working length for endodontic treatment would be shorter, which means it will be easier for you to negotiate with root canals. I would like to highlight one thing here. Just take a look. The level of the defect corresponded to the level of the gum. It's really, really, really subgingival, a super subgingival defect, and biological width is there. The good thing in that case was that this defect was not on the bone level, so the bone was slightly below because of the caries defect, and the bone was was redesigned by the immune system of the patient actually, and for us was it gave us some benefits for rubberdam isolation, because the rubberdam isolation in this case was super difficult. Step 1 of preparation was not that difficult. The caries excavation was not that difficult. The most difficult thing here was rubberdam isolation, and to do root canal treatment, to do proper build-up, we have to do rubberdam isolation in such cases. And there are a few tips and tricks that I would like to share with you in such cases. First, I did electrosurgery. I used the electrosurge. You can use laser or you can use burr just to remove some soft tissues around roots, around the sound tooth structures. That will be easier for you then to evaluate when you place your rubberdam isolation. Okay, once you remove some soft tissues, once you did some gingivectomy, you place some hemostatic liquid in order to prevent bleeding. Okay, I'm using viscostat, for example, from Ultradent. In these cases, I just put some viscostat and that's it. Then we do rubberdam isolation, and literally, I don't remember how many of rubberdam clamps I choose in that case to get that type of isolation. I tried Brinker clamps, I tried active clamps, I tried modified clamps, I tried everything, but the problem was that the clamps were not stable on the teeth, and they were jumping out from the surface of the tooth because of the pressure of the rubberdam. Then accidentally I found that regular clamp number 0 was perfect. It was stable, but it was stable until I was holding this clamp. Once I removed forceps from this clamp, it was moved really slowly by the rubberdam coronally, and afterward the clamp was running away. So actually, I thought, I was thinking how to stabilize this clamp, how to prevent mobility of this clamp. So basically, we have to push something and to hold this clamp on that place. I was trying to use flowable composite with the arch of the clamp to bond this to adjacent tooth. I was trying floss ties or whatever, and it didn't work until I found, again accidentally, I found the trick that this clamp, the wing of this clamp, actually stabilized that one for moving up. It was found accidentally. It was not like I know exactly what to do. I tried, I experimented. Now I would know what to do if I would need to stabilize clamp. I can stabilize the clamp within the adjacent clamp actually. But in that case, it was actually found accidentally. But now I'm sharing with you that trick. And if you would have something similar, now you will be able to understand how can you secure clamp by adjacent clamp. And what also funny is that I'm really against these wings, because these wings are not okay in case if you need to place matrix wing, which has some ring to do some composite restoration, for example. But in that case, this wing was super helpful. Okay, and you can see that that isolation was achieved by this wing. Anyways, after we obtained isolation with clamps, we went to another type of isolation, which we call horizontal isolation, because vertical isolation was obtained by the rubberdam itself. We used actually the heavy rubberdam membrane, and with the clamp we got this vertical retraction and vertical isolation, and then we selected Teflon tape to get some horizontal retraction of rubberdam and soft tissues to expose the margin of the tooth, to see what actually we do with the teeth, and then to be able to do a build-up and to get fit of material in that areas. So you can see here the view of the rubberdam displaced by the Teflon tape horizontally. Endodontic treatment itself was pretty simple. It was just removal of the endomethasone or zinc oxide eugenol paste with ultrasonic, then cleaning with ultrasonic, when a lot of irrigation, straight root canals, not very long root canals, so it was not that difficult. And I really love this picture because it shows how clean teeth are after removal of the caries. It has to be super clean from the caries lesions. And then you see the substrate for bonding is good, the dentin is good. Everything is perfect to get some bonding of your build-up material. In this case, we used fiber posts and core build-up composite material to restore coronal part. Actually, it was like a fiber post and core actually, because we cemented fiber post using this core material. So we have one solid piece of post, intracoronal and intra-root build up with the same material, with a one shot. So build-ups are done. You can see geometry, so it will be easy for you to understand where you need to improve your preparations. And then in this case, I continued preparing teeth with the rubberdam, because since I have rubberdam, no bleeding, no soft tissues, I can do some parts of the preparation and to get all benefits and comfort for myself for controlled preparation. Actually, I posted this picture recently on my social media, on Instagram and Facebook, and some people they said that this is the Photoshop, because it is impossible to have that level between rubberdam and tooth surface, because how can you prep teeth with rubberdam in such a way without getting this helicopter effect and tightening of this rubberdam over the burr when you are preparing teeth. Anyways, you can see some scratches on the rubberdam, and this is the same rubberdam membrane that I was using with for endo. I didn't replace it because the isolation was super difficult. So I was doing everything in one shot, let's say. And this is actually video, because we cannot edit video. We can edit a lot of pictures. If you want to use Photoshop, feel free. But again, we have to understand that it is not good to lie for your colleagues utilizing Photoshop. But try, if you still use Photoshop to make some defects, try to edit videos, because in 1 second of video it is about 25-60 frames, actually 60 pictures within 1 second of video. It is impossible. You will spend all your life just editing video. So I will share with you tips and tricks that will help you to feel safe when you prep teeth with rubberdam in that subgingival, let's say, defects. So first of all, you can see that I was using flat plastic metal instrument. I retracted rubberdam, and I was doing this preparation in presence of flat plastic instrument. And then I noticed that in areas when my burr was interacting with the rubberdam, nothing happened. So I just removed flat plastic instrument, and I continued preparing tooth with my burr without this flat plastic instrument. So to be able to be safe in case when you prep with rubberdam and unfortunately we have interference between burr and the rubberdam, you have to follow 3 main rules. First, you have to use heavy rubberdam membrane, and it has to be super tightened with a clamp and with Teflon, like in this case, in order to avoid faults. Okay. Second, electric motor and increasing handpiece. Turbine will not work. Pneumatic motor will not work. Electric motor will work, because with electric motor you can control speed, and speed in this case has to be really low. It's about 15-20,000 RPM. Okay, with that controlled continuous low speed, the helicopter effect will be not same as with a turbine. And rule number 3, burr has to be fine or ultra fine. So red stripe burr or yellow stripe burr. In this case, it will not scratch rubberdam that much, and the helicopter effect will be, actually you may skip helicopter effect, as you can see I skipped in that clinical case. So finally we finished the preparation with the rubberdam, then I removed rubberdam. We wait 5-10 minutes just to give some time for gingiva to go up. Then we placed retraction cords, and we finished our preparations without rubberdam. The reason why we finished preparation without rubberdam is that we didn't see the level of the gum with rubberdam. Okay, so we finished preparation without rubberdam. Then we put temporary crowns for this patient and kept our patient 4 weeks, because we need to keep 4 weeks in that kind of cases, because within 4 weeks the new epithelium connection, new epithelium junction developed. Okay, and here you can see picture when lateral incisors were treated. So actually we removed caries defects, we made composite restorations here, and this is this picture was actually taken 2 days after root canal treatment and preparations. And you can see now even the conditions of soft tissues are not perfect, definitely, but they are not super destroyed. Next picture that I would like to share with you is picture after 4 weeks. In this picture you can see that the gingiva is pink, no inflammation. The interdental papilla is on its way. The level of the finish line are in sulcus, which is perfect. So that means we are on the right way. And the reason why we are on our right way is that our preparation was precise and our provisional restorations were also precise. So basically we start to win the game for treatment of the biological width. And this is the picture before final impression. In that cases we do impression with a double cord technique. The first cord is in the sulcus, another cord is over, which one size bigger. We put second retraction cord, then we remove second retraction cord, and then we take impression. These impressions were sent to dental lab. Dental technician performed ceramic Emax crowns actually here, and once we got ceramic crowns, the process of cementation was not super difficult because we have already developed and performed nice emergent profile, the good architecture of soft tissues. So placement of the rubberdam now was easy task, not the same as it was during the very first appointment when we were cutting gum and we were fighting actually with the gum and with everything. In this case we just placed clamp itself without any extra support. We made inversion with a flat plastic instrument. We made another, we made also a horizontal retraction with a Teflon just to expose the margin, to control fit, to control excess of cement, to polish transition. So you can see before placing Teflon, by the way, you can see the isolation was pretty okay. The good isolation, inversion, vertical retraction, perfect. But horizontal retraction in such cases also mandatory, because horizontal retraction gives you possibility to see the fit of the restoration and to manage the excess of cement for during cementation procedures. So you can see some pictures that were taken with a DSLR camera with a twin flash, sandblasted teeth, proper adhesive protocol. We can bond to enamel, we can bond to dentin, we can bond to composite utilizing the proper bonding protocol. And what is super important also is to check dry fit. Okay, here is dry fit control, which means there is no cement, there is no try-in gel, nothing. It's just dry fit, so you can evaluate the precision of the restoration. The restorations have to be super precise. And also what is super important in such cases is to get the X-ray control to see the fit of the restoration after cementing process. And there has not to be any overhang, any cement, etc. So in that case you may expect that the soft tissue conditions will be pretty nice. These pictures are just immediately after cementation. This is some information about black triangles. Actually, if the distance between bone and between interdental contact point is less than 5 millimeters, you may expect that this distance will be filled with the interdental papilla and there will be no black triangle issue afterwards. And also the distance between interproximal areas, if the distance is less than 3 millimeters, in most of the cases, in 98% of the cases, you may get this space filled with papilla. In our case, we use this calibrated ruler. It's about 5 millimeters, so we can expect the growth of papilla in interdental areas. This picture is after 2 weeks. You can see that the papilla is on its way. It's just a small piece of papilla that will be filled definitely in a while, but unfortunately I don't have another picture because patient was from another city. She was pretty happy with the result. She left to another city, and when we were calling her to come to our clinic one more time for checkups, etc., she said, I'm pretty happy with the result. My feelings are there, my crowns are there. interdental papilla is there. I don't have this black triangle between teeth, and actually she didn't come. Unfortunately, because I would love to see that, the final result, to evaluate the final result, considering the fact that this case was done in 2014. Since now, everything is fine. But I would definitely be more insistent to find this patient again, to ask her to come, because actually she's from another city in another country, so not easy for her to travel to my clinic more times. But maybe, actually I got the idea right now, by the way, I can ask her to come to any dental office and just to take picture and to send me. So I will be an X-ray. So I would be happy to see that final result and to share these results in my presentations. We are done. Conclusions. In this case, if you go into compromise approach, you have to do best option, not best options, because the best option maybe was orthodontic treatment or crown lengthening. But I mean, if you do compromise type of treatment, the steps of your compromise treatment have to be perfectly done. Preparation, perfectly done. Temporary crowns, perfectly fitted. Final results, super precise. In this case, you may expect nice result, biological and aesthetically driven. Okay, my friends, I would like to ask you, write down in comments, please, what kind of clinical cases you also would like us to share. What topics actually? Maybe you would like us to share some endodontic cases, to go more into endodontic details. Maybe you would like us to show some direct composite restorations and go more into the detailed explanations of layering technique, finishing and polishing technique. Maybe you would like to see more veneer cases. Maybe you would like to see more complex cases, let's say. Just write down comments, and we will evaluate these comments, and according to your comments, according to your requests, we will film next episodes of BG Dental Cases video tutorials, driven by your request actually. Okay, so I was super happy. To spend my time with you. I would be more than happy if you will get some tips and tricks that you can implement in your daily basis. So keep in touch, my friends. Don't forget to subscribe to our YouTube channel and to switch on notifications, because I would like you not to miss our nice content that we share with you absolutely free of charge. Keep in touch, and bye-bye.